Good evening, everyone. A very warm welcome to all participants joining us for this exclusive insight session on IDA 2025 Airway Guidelines. This session is organized by All India Difficult Airway Association, and I am Dr. Amit Shah, General Secretary of All India Difficult Airway Association. It is my honor to moderate today's interactive sessions, which brings together the distinguished authors of IDA 2025 guidelines, which were published in Indian Journal of Anesthesia November issue yesterday. This guideline represents a significant update built on evidence, expert consensus, clinical practicality to enhance management of unanticipated difficult airway in adult, pediatric, obstetric, and extubation of at-risk scenarios. So today we have with us a very expert who led this monumental work, and they will share their insight into methodology, rational recommendation, shaping the next phase of airway safety in India and beyond. So let's begin our session. To open this session, I will call upon Dr. Pankaj Kundra sir, Dean JIPMER Pondicherry, and Chair of IDA Guideline Committee, past President of IDA. He will set the stage with introduction for the vision and purpose behind this guideline. Kundra sir.
Good evening to everyone, and thank you, Dr. Amit, for the kind introduction. Well, I'm not Dean Academic anymore from JIPMER. I'm former Dean there. But yes, Dean of Pondicherry University as an honorary post. Welcome all of you for this session on update of IDA Guidelines 2025. It's been a pleasure to work with my team here who has given a lot of their time and energy and put in a lot of efforts to bring out these guidelines. We have been working on them for past 2.5 years. And I have forgotten the number of counts that we had to revise the draft. And we just kept revising it till the final draft when it was ready. Even in the final draft, we had so many changes to make repeatedly. So thank you all the guideline committee members, IDA executive members, and all the IDA members and people who have joined in to get an update on 2025 difficult airway guidelines. So just to give you a small preamble, the entire work started about 2.5 years back when we could see that there are numerous changes which are happening, and we had to incorporate those changes to modify our existing guidelines which were published in 2016. So this time we ventured out in a more broader, inclusive manner. We were able to request the Association of Obstetric Anesthesiologists India and the IAPA India to come and collaborate for the obstetric unanticipated difficult airway and for pediatric unanticipated difficult airway. So these two societies, their members were nominated, who worked with the IDA members, the guideline committee members, and brought out a wonderful and a very robust looking guidelines which are now published. If you would just browse through them, you will find that a lot of research has gone in, and whatever is being published is all evidence-based. Nothing is hypothetical, and places where we could not get a proper evidence, we had to go for expert consensus with the Delphi method, for which there are 2 articles which have also been published, because Delphi is one of the ways you have to get to give us a recommendation of what we should be doing. So Dr. Sheila has done that work for us. So there is a special section for Delphi and methodology, how we have gone about collecting evidence and formatting these guidelines which have come into picture now. So you would see that India is taking lead, and it is all Make in India now as per the government of India's proposal. We are having our own guidelines. That's a remarkable job which has been done by all the team members here, including all of you who have given us a very sound input to build this guidelines in the shape which it has achieved today. So with this few words, I'll hand over the proceedings to Dr. Amit. And the agenda he has already detailed. Each one of the guideline committee leads would present the algorithm and brief about the changes which are there from the 2016 guidelines. I will take permission from all of you to excuse me because I am on a private function here, and Dr. Rakesh will do the needful. He's anyway. I mean, it's any one of them can do the needful because every one of us has gone through in minute details with all the guidelines which have been published. So it need not be the lead who has to do it. Any one of the members would be well acquainted and would do a similar kind of a job. So that's how the guidelines have come up. It has been so minutely looked up and revised. So thank you for joining in for this session, and I congratulate all our members to have seen the final version of it published in Indian Journal of Anesthesia yesterday. Thank you. Thank you very much. Over to Amit.
Thank you, sir, for those words. Next, while as Kundra sir already identified that we have really followed a very robust process, and there are two papers, actually separate papers about one about methodology and about Delphi. To tell you about that and adult guideline in detail, I'll welcome Dr. Sheila Maitra, Professor of Anesthesiology and Critical Care at Tata Memorial Hospital, Mumbai. She is past president of AIDA, lead for adult guideline, lead for methodology document, and main pillar behind Delphi process. So she will take you through all these three methodology, Delphi, as well as adult guideline. Over to Dr. Sheila.
Good evening, everyone, and greetings from Tata Memorial Hospital and greetings from All India Difficult Airway Association. It is indeed a great pleasure for me to present the methodology, the Delphi process, and also the adult guidelines and be the opening batsman of this session. As Dr. Kundra has already outlined, this has been a long journey, and we have evolved and we have learned through the process. And this time, because our methodology, as has rightly been pointed out, was very robust, we decided to have two separate documents, one publishing the methodology as a whole for all the guidelines, and another document talking about the entire Delphi process that we adopted to generate consensus for areas where there wasn't very robust evidence. So in the interest of time, I'll put you through this briefly, but I really urge you to read each of these manuscripts. When I was sharing this with my international colleagues, they couldn't believe that AIDA could come up with 7 documents in this kind of time, because they take 2 to 3 years to come up with one document, but we have come up with 7 documents that have been published online simultaneously in IJA yesterday. So I'll just start by giving a brief overview on what was the need for development of these guidelines, which Dr. Kundra has already alluded to. But as you know, 2016 to 25, there's evolution of technology, additional published evidence is there, and also this has resulted in changes in our clinical practice in the last decade. So it was important to update this. A really important thing that the previous algorithms, and I would say most international algorithms, do not provide guidance for a failed supraglottic airway insertion, face mask ventilation, or any other strategies that are commonly used as part of general anesthesia as our primary airway management plan, other than intubation. So all guidelines for unanticipated difficult airway are intubation centric. And we know today intubation is not the only way by which we are giving general anesthesia. In fact, we are moving away from intubation into a little more and more non-invasive techniques. So we definitely need guidance for what happens when these devices fail. And more importantly, though we had airway experts in the previous guidelines, we felt a need for the involvement of both obstetric and pediatric airway experts for the obstetric and pediatric guidelines. And most importantly, for the extubation guidelines, we already had a very robust algorithm, which was much appreciated internationally, because in a single page, we were able to encompass almost every situation that was required for extubation. But there was a need for the risk evaluation prior to extubation to elaborate on that, identify at-risk extubations, and this justified further improvement in the extubation guideline. In addition to this, in the last decade, there's increasing role of ultrasound in airway management. We also have Sugamedex available. So it was important to include this across all the guidelines. So this was a basic background for updating of the guideline, not just the passing of the time. So I'll talk briefly on the methodology, but I'm really proud about this because we used a really robust methodology. We said we shouldn't do the same thing as a couple of us getting together and just having consensus on whether it should be 3 attempts, whether we should use VL, should not use VL. So what we did is it was based on a literature review. We had PICO, that is population intervention comparison outcome questions that were formulated through consensus among the steering committee for each of these guidelines. So we had, a lead group, a steering committee, and then for each of the guidelines, adult, pediatric, obstetric, and extubation, we had a subcommittee. For each of them, we had PICO questions, and we did a systematic literature search. Data extraction was done, and an evidence synthesis was done for each of them. We had a concept table, and for each of them, we had Prisma diagrams, and 2 reviewers independently screened the titles and the abstracts of each. And then finally, the list of articles that was selected were once again reviewed. And most importantly, though we didn't use the classic grade recommendation, we did use grading. And actually, it is incorrect to call any say recommendations in guidelines if you have not used grade. So I'm really glad that we have evolved over time and we've actually used grade. And what we used was the AHA class of recommendation and level of recommendation was used. And in addition to this, there are many interventions during unanticipated difficult airway that we perform where the evidence is not very strong, or there's weak evidence, or there's absent evidence. Now, grade doesn't fit in very well for that. So we used a very robust Delphi process to generate consensus among the experts, and I'll talk to you about that in a bit. So this is the AHA class of recommendation and level of evidence that we followed. We had the class 1, 2A, 2B, etc., and the level of evidence A, B, C, D. And so once we got the evidence synthesis, the steering committee went through, sat through each recommendation and we graded it. And AHA also gives you the language and the phrasing that you could use. So we also decided, through consensus as to what phrasing we would use. So what you see for every recommendation that we have proposed, there will be a level 1A or a 2B, and also the quality of evidence. And as I mentioned, for each, it was a very robust process. And here I want to thank Dr. Amit Shah, who along with a librarian did this process for us. So for each concept table that was prepared and for the search strings, a Prisma flow diagram was prepared. And, a very robust literature search was done when we narrowed down to the articles which were finally reviewed by the 2 experts. Now, this was what was done for making the recommendations. Where the evidence was weak, we still needed to give some guidance to the clinicians. So we used Delphi methodology. And here, this is the next best thing to do when the evidence is either absent or weak. So the steering committee, they initiated this process. And what we did is we involved experts. Now, these experts were a separate group. The steering committee members did not participate in the Delphi process. And these experts, we had predefined criteria. So they had to be people who were teaching, training, had publications in airway management, and were involved in advocacy with airway management. So the experts were very carefully selected. And the beauty of this was the identity of the experts was not revealed till the end of the iterative rounds. And this was to avoid any bias or group pressure while generating these consensus statements. So the statements were included. So as the Delphi process, you have iterative rounds. The first round is an open round where people give feedback. And subsequently, based on the results of each round, we would provide a report for the next round. And then we would put the questions further until they achieve consensus and also stability. So the consensus was taken as about 75%. When 75% or more of the panelists selected the same option, and we had 2 types of questions. We had multiple choice questions and we had Likert scale questions. So when we had consensus, we looked for stability. Now, what was stability? Stability is looking at there shouldn't be variation between the responses. So between 2 of the iterative rounds, if there was stability and the p-value was taken as 0.05, when consensus and stability was achieved, the question would go out of the Delphi process, whether there was consensus or dissensus. And then as we proceeded with each of the iterated rounds, the number of questions kept on reducing. Now, based on the feedback, we also modified the questions. And finally, based on the consensus and stability, whatever generated consensus, we drafted expert consensus statements. These were, of course, not recommendations, but the next best thing that we could do. And based on, we use these to draft various aspects of our algorithm. And for our algorithm, it was important to provide guidance. For example, something like, should we have 2 attempts at intubation or 3 attempts at intubation? So a priori, we decided that if we did not generate consensus through the Delphi for these statements, which were very important in the algorithm, it would be put to the steering committee, and then the steering committee would have a vote on this, and then whatever item received the maximum vote would be included in the algorithm. So I'm really proud to present this document, and really I present this on behalf of all our members of the steering committee and the co-authors of this. And this is the document on the management of the unanticipated difficult airway and in adults. And you can see all the co-authors here. And importantly, remember, we are talking about unanticipated difficult airway under general anesthesia, right? So it's important to remember that we are not talking about when you have a difficult airway under, when you are doing an awake intubation. So this is general anesthesia, any form of general anesthesia if you have an airway difficulty. The disclaimer is very important, and we felt it was important to reiterate certain points. We remember that last time when we introduced capnography, there was a lot of criticism. People said capnography is not available. And despite this, we kept capnography because we thought it was important. People would at least try to get a capnography. So the disclaimer says that these guidelines are supposed to help clinicians manage unanticipated difficult airway in patients using evidence-based recommendations, as I mentioned, or Delphi consensus. And important to remember that these guidelines are not the law. So the guidelines do not represent the minimum standard of practice, and nor are they a substitute for good clinical judgment. And most importantly, the recommendations assume that the airway operator has adequate experience with the device and technique described, and these are applied within the scope of their practice. This is very important. And recommendations regarding the use of specific devices or medications or workforce apply where these resources are available. And these recommendations should be viewed as aspirational when this is not the case. For instance, if we say capnography and you don't have capnography, then these should be aspirational, and one should try to get it rather than say, oh, I don't have it, so I will not try to use it. And most importantly, the authors also acknowledge that the literature related to airway management is rapidly changing, altering our attitudes and clinical practice. So there may be many things that come in future that cannot be updated very rapidly. So we have to keep that in mind. And most importantly, it's important to note that application of these recommendations in specific settings remains finally the responsibility of the clinician. So this is the disclaimer across all the guidelines. So I thought I should give it to you upfront. So let's come to what the algorithm looks like. And as Dr. Kundra sir has said, when I first proposed this diagram, I can tell you, I don't know, Amit will clarify me, we must have had at least 70 or more than that changes in the, diagram. And that just shows, the kind of brainstorming that went to make it better and better and better. And I won't say it's the best, but a lot of input has gone to fine tune this algorithm before it was finalized for the adult, and then it was modified for the pediatric and the obstetric. So this is the algorithm for the adult. Okay, it's quite colorful, and I'll go through it point by point. So this is the All India Difficult Airway Guidelines for the management of unanticipated difficult airway in adults, and as I mentioned, under general anesthesia. So coming to the first part of the algorithm, right? So in the beginning of this guideline itself, we've got given a lot of good content as how to prevent, how to optimize your laryngoscopy, how to optimize your circulatory airway device insertion, mask ventilation, etc. A lot of strategies as to how to prevent an unanticipated difficult airway as far as possible, including human factor consideration, etc. So there's a lot of good content in the guidelines, which I urge you to read. But God forbid, if you reach this kind of situation, what you're supposed to do is outlined in this algorithm. But again, seeing the algorithm in isolation is not appropriate. You need to read this along with the text. But in the interest of time, I'll just give you a very quick overview. So, of course, pre-oxygenation, induction of anesthesia, and the primary airway management plan. Now, primary airway management plan is very important. And here is where we have moved away from being an intubation-centric algorithm. So primary airway management plan can be a tracheal tube, supraglotic airway device, it could be face mask, even nasal cannula, oxygen cannula, it could be high flow, or any airway adjuncts. It could even be a nasopharyngeal airway or oropharyngeal airway. You could be giving TIVA, any general anesthetic where you use this device alone or in combination, and in spontaneous or controlled ventilation. So any form of general anesthesia that you're giving, this algorithm applies to this. Now, if you're successful, then of course you're good to go. Please continue as planned. And again, when we talk about success, we talk specifically about using waveform capnography. And this is from the Project for Universal Management of Airways, the PUMA guideline, which is endorsed by the All India Difficult Airway Association. So we look at 7 consistent waveforms of capnography without any decline. This is the kind of trace that you should see. These traces. So it's really, really important. We've given emphasis on this as to how to confirm the position of the tube with waveform capnography, or whether you're using mask or supraglottic airway devices. Right. So this is a situation where it's good and you continue as planned. Now, if you have a situation where you're unsuccessful, okay, maybe your mask ventilation isn't going good, or supraglottic airway device fit is not good, or you are unsuccessful, whatever, if you are unsuccessful in any of these plans, okay, and then if you see the left side of the algorithm, we emphasize these 3 vertical bars, which I'm going to be talking about, calling for help. Now, this is really important. Calling for help when you face the first difficulty, and we've talked about code D. There's a separate paper on this. Now, code D is really important. For the first time, we have proposed the code D. D stands for difficult airway. So rather than just a generic call for help, it's a very specific call for help. When you say code D, you're talking about this is an emergency and this is a situation where there is an airway difficulty. So you can have, someone who's experienced with airway management coming. It's a more specific kind of call. And most importantly, in the process of resuscitation, maintaining depth of anesthesia is really important. And we have highlighted peri-procedural oxygenation. So continue nasal oxygen. Even for routine airway management, we have talked about giving nasal oxygen during periods of apnea. So you continue the delivery of nasal oxygen during the attempt. And this is a 3 bars on the left side of the algorithm. And remember the code D, this is something new and novel that we have proposed. So coming again with the unsuccessful part, if you are unsuccessful in any of the devices that you've used for general anesthesia, then you come into this orange box. Okay. And when you come into this orange box, you need to use one of the following devices. Now let us look at this a little more in detail. So we have 3 lifelines. We have the endotracheal tube, we have the supraglottic airway device, and we have the face mask. And if you see these arrows, they are bi-directional arrows. So it's not necessary if you failed intubation that you have to go to supraglottic. You can even go to mask ventilation. So this shows you that you can interchange. You should keep interchanging clockwise, anti-clockwise, whichever way between the 3 lifelines, because your primary objective is to establish adequate ventilation and oxygenate this patient, right? So we don't want people to be fixated with just putting a tube again. Well, you may go ahead with a second attempt at the tube, or you may move to any of these devices. So remember, consider interchanging between these devices, right? So this is really important. Now, to do this, every attempt must be something to improve the chance of success. So don't do the same thing again and again and again and again, which is what we tend to do, because you have, a lot of human factor consideration, tubular vision, cognitive overload. So consider optimizing the position. Ensure that there's neuromuscular blockade. Change the tools. I've used the endotracheal tube, now I'll try for supraglottic. Change your technique, and also consider changing the operator. Same person doing it again and again, consider using a senior or some other experienced operator in that technique. So this is really important. And the other thing is about limiting attempts at device. And we know with each successive event, there is increased chance of complications. Now, we thought a lot about this. We brainstormed a lot about this. And through Delphi consensus, we got maximum 3 attempts. And if you look at it, we haven't set 3 attempts like most guidelines say. We have set 3 failed attempts. And I'll tell you why in a minute. And this is because mask ventilation is a non-invasive technique. So it's ridiculous to limit the attempts at mask ventilation to only 3. I can go on and on doing mask ventilation, but I can't do the same with supraglottic airway device and endotracheal tube. And therefore, we say 3 failed attempts. So until, because you have to have some exit criteria from this box, and therefore it is important to give a limit on the number for the mask ventilation as well. So we said 3 failed attempts. You failed your tracheal intubation 3 times, or maximum 3 supraglottic airway device. Or now again, remember, this is the maximum. It doesn't mean that you have to do 3, 3, 3. Okay, you could transition, move out of this at any point, but this is the maximum when you had 3 failed attempts at each of these devices. Another important thing, which was very novel, which we had even last time, we said attempt tracheal intubation only if the saturation is more than or equal to 95. And this is really, really important, because it's important to re-oxygenate between attempts at intubation and not say that because I have 3 attempts, I just intubate whether the saturation is 80 or 70. So re-oxygenation is important. And remember, there's a lag time for this pulse oximeter. So what you're seeing as 95 may actually be 92. And this is why we have a higher cutoff, also keeping in mind the oxygen dissociation curve. So this is common to all the guidelines. That's why I'm focusing it on a bit. And remember to interchange between these devices in any order. What your goal is to establish ventilation and establish, oxygenate the patient. And most importantly, we've added keep track of time and SpO2, the saturation, because this is what we often forget, how much time is lapsed. And this is what happened in the Ellen Bromley case as well, because people have, you completely lose track of how much time has passed. And the saturation is, of course, very important. Now, if you're successful, then that is great. You move to the right side. Every time you're successful, we have an exit towards the right. And here, again, we have given, it's a little different from the previous guideline. And what we've said, let's look at it a little carefully. So if you put in an endotracheal tube, then of course you confirm with waveform capnography. I've already talked about it. Now, if it's a supraglottic or a tube or a mask ventilation, if you use any of these devices to achieve effective ventilation, then you have many options. You can awaken the patient if it's not important to proceed with the surgery. If it's considered safe to proceed with a surgery, small breast surgery, whatever, I can continue the procedure with either of these devices. Now, this is some recommendation specific for supraglottic. When you put in a supraglottic airway device, if you want to intubate for that surgery, say it's an abdominal, laparotomy or something that you have to do where a tube is necessary, it is really, really important to consider intubation through the device. Don't remove the device, and only if you have a flexible bronchoscope or the expertise is available. Otherwise, you shouldn't venture to do this blindly, and you shouldn't venture to do blind intubation. I just strongly discourages any blind intubation through the supraglottic airway device. And in some very remote settings, even tracheostomy may be an option. For example, you don't have access to bronchoscopy and you need a definitive airway for this patient, then you may even consider tracheostomy, and that may be the safest option for that patient. Well, if you proceed to the right side, you're able to ventilate, then you're good to go. If that is not the situation and you are unable to ventilate this patient using any of your three lifeline, then you reach a situation that we call the complete ventilation failure. Now, what do we mean by complete ventilation failure? And this is what we used in our previous terminology. And this is the inability to ventilate using the tracheal tube or the supraglottic airway device or the mask ventilation, all the three lifeline, despite the best attempt after using a neuromuscular blockade, despite preservation of the saturation. Okay, even if the saturation is maintained, we declare complete ventilation failure. Now, when there is complete ventilation failure, we call for additional help. Okay, this is really important. We had it in our last guidelines. In fact, when I was part of the ASA guidelines, they like this term so much that they have incorporated this in the ASA guidelines. And the reason for calling additional help is not only to get an extra helping hand, but also considering the human factor considerations. At this time, there's a lot of cognitive overload. You have tubular vision. You lose sight of the big picture. So that additional help, person who comes is not in this stressful situation and may be able to perform better and give you some better cues as to what you could do. And therefore, this call for additional help is really important at this absolute crucial juncture when you have complete ventilation failure. And of course, we need to continue the efforts at rescue mask ventilation. And then the option is to do the emergency surgical cricothyrotomy. And the big change from our guidelines is the emergency surgical cricothyrotomy. In the previous iteration, we recommended that you could do any of the three techniques. Either you could do needle cricothyrotomy, emergency surgical cricothyrotomy, or you could use the commercial kits. You could use any of them. But based on the evolution of the literature, there is more data to suggest that surgical cricothyrotomy is a preferred technique. So we say do surgical cricothyrotomy. But of course, if you're experienced to do the other techniques, we don't say don't do it. But we said that should be, lower down in your priority. And as far as possible, we should do surgical cricothyrotomy. Now, coming to the complete ventilation failure, and why is this time point? Why should this be the trigger to escalate to doing an emergency cricothyrotomy? And I'll talk to this. And this is a very beautiful graphic that we have in the paper. Now, complete ventilation failure. Now, when you have a situation where you fail to ventilate the lungs despite using the three upper airway device, the endotracheal tube, the mask, and the supraglottic airway device, you're in a situation where eventually the saturation is going to fall, and from 100 is going to plummet down to 0. And from the situation where you fail to mask ventilate or intubate or put a supraglottic airway device, you're going down to failure to oxygenate the lungs, failure to, ventilate, oxygenate, hypoxia, cardiac arrest, and eventually brain death if you're not able to do anything. Now, what we say is that when you have failure to ventilate the lungs, right, that is the point when you should initiate. So we say declare complete ventilation failure at this stage when your saturation is preserved, because ventilation failure results in oxygenation failure. It precedes oxygenation failure, and that should be your trigger to start the emergency cricothyrotomy rather than when the patient starts desaturating. And there are, of course, a lot of human factor consideration. And cannot oxygenate today is not a terminology that is very well understood. And this is because for some people, it cannot oxygenate means cannot ventilate. It means that oxygenation is not preserved. or it means I cannot, conduct, maintain oxygenation in the patient. So it's not a very well understood terminology. And most importantly, in the era of apneic oxygenation, I may be able to preserve the oxygen saturation at the same 100% for a long time. But what is inevitable is once I am unable to ventilate the patient, desaturation is inevitable. Whether it will take 10 minutes or 30 minutes or 1 hour, I don't know, but desaturation is inevitable. So it's better to do the emergency cryotherotomy when the saturation is preserved. And that is our rationale to declare complete ventilation failure. And if you see the ASA guidelines, if you see the Canadian guidelines, they have all started with cannot ventilate and do not encourage this cannot oxygenate because it's an ambiguous terminology. And when you talk about cannot intubate, again, our algorithm is not intubation centric, and cannot intubate kind of becomes redundant today because intubation is not the only way to ventilate and oxygenate the patients. Coming to the emergency cryotherotomy, as we said, we have given our preference to surgical cryotherotomy, and the technique we have recommended is the SAP tube bougie twist, stab twist bougie tube technique. Okay, this is kind of a mnemonic to remember this very easily. Now, the scalpel bougie technique talks about giving an incision, and we feel anesthesiologists are not very comfortable with giving an incision and doing blind dissection, and that is why the stab twist technique. So you stab the vertical, a horizontal stab at the cricothyroid membrane, and then you rotate the scalpel by 90 degrees, okay, with the blade facing quadrantally, and push the blade towards yourself so that you generate some space through which the bougie can be guided in, and then you guide the bougie in and by 7 to 10 centimeters, and then subsequently you railroad the endotracheal tube over this, and then you can remove the bougie, and of course you have to confirm this with the waveform capnography. So this we think is going to be simpler than taking an incision and doing blunt dissection. But of course, if you're comfortable in either cryotherotomy or you have any of the commercial kits, you can go ahead and proceed with it. Another reason for recommending the surgical cryotherotomy is because of it's universally available in a resource limited settings to have a 10 number blade with scalpel and to have a bougie and a 6 number endotracheal tube can be available anywhere across the country. And we just need people who are trained to do this. Now, post-procedure plan is very important. Remember that whenever you've had an unanticipated difficult airway and you've got out of the situation, remember you may need to have a further airway management plan. For example, if you've done cryotherotomy, you may need to convert this into a tracheostomy. Airway edema, the airway may worsen, so you may need evaluation. If there's airway edema, you treat it even if it's suspected. And most important, monitor these patients for further complications, bleeding and other complications, and counsel the patient and their family if possible, and document this. We've also given a special airway alert form, which is part of another document, and for a standard documentation whenever there has been any of these events. So this is the algorithm for the unanticipated difficult airway in adults. And for the subsequent algorithms, there are subtle changes that are present. And I just want to, just for 1 minute, talk about the recommendations or the best practice statements. And we made, for 3 of the tools, we made recommendations. And this is because we had good we had good evidence to support it based on the AHA grading. So the first one was, does video laryngoscopy improve the success rate of intubation compared to direct laryngoscopy? And our statement is that video laryngoscopy improves the success rate of intubation compared to direct laryngoscopy and is recommended to be used as a primary device or also in rescue situations. And this recommendation and the strength of evidence it's a grade 1A and level of evidence is 1A. So this is the only one where we were able to give a 1A recommendation. So the default should be to use a video laryngoscopy. What about the use of bougie or stillet? And a bougie or a stillet may be considered to improve intubation success with a Macintosh blade laryngoscope. And the stillet is beneficial when a hyperangulated video laryngoscope. So the evidence wasn't that robust. It was a 2B, 2A. And what about apneic oxygenation during intubation to reduce the risk of desaturation? And we said apneic oxygenation can be beneficial to reduce the risk of desaturation, and it's a 2A recommendation. So the last 3 are best practice statement, whereas video laryngoscopy is a 1A. And where the evidence was not very strong, we used consensus using the Delphi process. And here you can see what is the percentage of the consensus. And regarding neuromuscular blockade, we said it should be administered. Now, this is very controversial when there is difficulty in mask ventilation. And we said it improves your mask ventilation, improves your lung compliance, and we should make every attempt to improve the success of intubation and ventilation. Laryngoscopy should be reattempted following a failed intubation only when saturation. So the cutoff value through consensus was more than 95%. So you reoxygenate in between and get the saturation 95%, and a maximum of 3 attempts. So for tracheal intubation, it was maximum of 3 attempts. could be permitted before, to prevent airway-related complications. For supraglottic, there was no consensus, and therefore this was taken to the steering committee, and the consensus was again for 3 attempts. And for surgical cricothyrotomy, should be performed when there is complete ventilation failure. So there was already consensus for this. So I will leave you with this, and please do go ahead and read this current issue, the November issue of the IDA, because it has all these 7 documents that will be soon discussed. And with that, I thank you very much for your attention. Happy to take questions.
Thank you, Dr. Sheila, for that. I would say excellent review. Not very, in the sense, not comprehensive. If Dr. Sheila start talking about this guideline, she'll talk for at least 2-3 hours, because that much in depth she has gone for this, and she can really talk in detail about it. So still excellent and complete overview of this. As she has already outlined, you must read entire document to get what we have proposed. So next, we'll as we are watching also for the queries. So if you have any queries, if you're on a YouTube video, please put it in the chat box. We will definitely answer each and every query. Next, we'll focus on a pediatric airway, the area that demands precision and special care. To present this section, I'll invite Dr. Jason Doctor, Professor in Anesthesiology and Critical Care at Tata Memorial Hospital and Critical Care Center, Mumbai. He is lead for Pediatric Guideline and is also active part of all other guideline documents. Over to Dr. Jason.
Thank you, Dr. Amit, for the kind introduction. So I'll maybe just... My screen is visible, right?
Yes. Yes.
So good evening, everybody. And I will be talking about the IDA 2025 guidelines for the management of unanticipated difficult airway in pediatrics under general anesthesia. So this was the paper that was published yesterday morning in the IJ November 2025 issue. And we have majority of the authors logged in over here. So in a nutshell, this is the algorithm for the management, and these guidelines have been recommended for difficult airway management in children between 1 and 12 years of age. So I'll take you through the subtle differences that are there in the pediatric guidelines and what is different from the 2016 guidelines, as well as what is different as far as evidence is concerned over the last 9 years. So before we begin, a disclaimer here, that this is a very robust methodology, like Dr. Sheila Madam described, that we have evidence-based recommendations and a Delphi consensus opinion from various airway experts. And they have adequate experience. It is recommended for people who are having adequate experience with the devices and techniques. Literature is rapidly changing. A couple of years ago, when we published the earlier guidelines, the airway management plan was predominantly intubation, and over the years, we have increased the use of supraglottic airway devices, mask ventilation. Post-COVID, we have increased the use of apneic oxygenation techniques and high-frequency nasal cannula. So it is important to note that the application of these recommendations in specific settings remains the responsibility of the clinician who is taking care of the child, especially more so because pediatric population is different. So how do we have the 2025 guidelines different from the 2016 guidelines? So like which was described in the earlier presentation, we have an evidence-based recommendation with robust methodology, and we have used the AHA classification with the level of evidence. And wherever this evidence was lacking, you saw the colorful flowchart that was the table that was described earlier. And wherever evidence was lacking, we took consensus opinion, and we used a Delphi process among the airway experts to generate expert practice statements. So in the guideline, this was the summary of recommendations and best practice statements. This is a busy slide, but I will take you through each of these recommendations when I describe each of the components in the algorithm. And this was the consensus statement using Delphi methodology. So the second difference from the 2016 guidelines was this was a collaborative effort by pediatric experts, not only by IDA, but also from representatives from the IAPA, that is Dr. Anila Malde, Dr. Neerja Bhardwaj, and Dr. Sandhya Yadnapudi, which were from the IAPA, and together we designed the algorithm and looked at all the evidence that was available from the year 2000 to 2024 about all the various components. So in the third difference that is there is in the algorithm design. In the 2016 algorithm, we began with the premise that the primary airway management plan was intubation. If you can see here. So what if the primary airway management plan that is over the years that has changed was a supraglottic airway device, a face mask ventilation, a nasal cannula, other airway adjuncts. So this had a hierarchical design in which you could not return. Suppose your primary airway insertion plan was a supraglottic airway device. There is no way that you could go back onto step 1 or try an intubation, and you had to follow the hierarchy or order down onwards. So there is no provision for going from step 2 or 3 to step 1. Versus in this algorithm, like you saw in the adult algorithm, this has a variety of choices. So if you have inserted a supraglottic airway device, you could either do a laryngoscopy and put an endotracheal tube, or use a face mask ventilation, and it had bidirectional arrows. So we introduced a terminology that is the code D that has been introduced to indicate that the patient has a difficult airway. So the moment a code D is described, everybody is aware that we are dealing with a difficult airway, and a difficult airway cart is mandatory to be taken to the site where the call was raised from. So coming to the algorithm, the pediatric algorithm and the guidelines of 2025, these were all the differences. And now coming to the main algorithm. So here, like we described earlier, pre-oxygenation and induction of anesthesia with the primary airway management plan, which could be, and it could not be limited to only intubation. It could be insertion of a supraglottic airway device, a face mask, a nasal cannula, airway adjuncts, either using spontaneous or controlled ventilation. And success has been defined as can maintain adequate ventilation and a saturation of more than 95% and a waveform capnography with 6 square wave capnograph breaths if you have been using any of the airway management devices. So this was, if it was successful, you continue as planned. If it was unsuccessful, then you move on to the circular algorithm. So unsuccessful is defined as inability to insert an airway or maintain adequate ventilation or maintain adequate saturation. Now, if you are unsuccessful, and before I move on to the circular algorithm, the 3 bars, that is introduction of the new term that is call for help, which is code D, and it preferably in the pediatric guidelines involves a pediatric airway expert. So when you raise a call for code D with a pediatric guideline, please make sure or ensure that you mention that it is a child. And if you have a pediatric airway expert in the hospital who is proficient with the use of pediatric equipment and managing the difficult airways in children, please request them to come to the site where the call has been raised from. So it is defined as to whom you need to call for the help. Depth of anesthetic has to be maintained all throughout, and continue nasal oxygen or for apneic oxygenation with a flow rate. So here we have defined a consensus statement and statements for apneic oxygenation. So here when we say high frequency nasal oxygen or low flow nasal oxygen is beneficial in increasing the time to desaturation in pediatrics between 1 to 12 years of age, and we have put a best practice statement because we have robust evidence in the form of randomized control trials, and it is claimed to be beneficial. So when you go through the entire guideline document, we have a Prisma flow chart, and we have all the relevant papers which are collated in a table format, and that gives you all the evidence. That is why we have put a best practice statement. Now, when we went through the literature, we could not identify as to what flow rate. There is not a single paper which tells you this way or that, and that is why we have formulated a Delphi consensus statement, and we had run through a Delphi process, and a nasal flow rate of 1 to 2 liters per kg per minute using high frequency nasal oxygen should be used for apneic oxygenation during attempts at intubation in pediatric patients. So earlier we were mentioning a flow rate, but that was not from a robust methodology document. Even now, we do not have evidence. So that is why we have put a Delphi consensus statement, and the consensus was 92%. Coming to the circular algorithm, so this has a circular design. So if the primary airway management was a supraglottic airway device that was inserted and you were unsuccessful, then you could either attempt a second attempt at supraglottic airway device, or use intubation technique with a video laryngoscope or direct laryngoscope, or use a face mask ventilation. and vice versa. If the primary airway management plan was intubation, then you could move either with a second attempt at intubation or any of these other devices. So there is no hierarchy. You may do any of the other techniques. So now what is different is in optimizing face mask ventilation in children, maintain adequate depth of anesthesia, maintain patency of the upper airway. There is a lot of soft tissue, so you have to be very gentle, and we have to make sure that the soft tissue is not being pushed inside the oral cavity and compromising the oral cavity space. The head has to be maintained in neutral position, like you know that children have an enlarged occiput, and you don't want the neck inflection and the tongue fall happening. So that is why head has to be maintained in neutral position. Use appropriate size airway adjuncts, that is a nasopharyngeal or oropharyngeal airway if required. Ventilation with a two-person bag mask technique is often helpful. Consider a lateral position for the child. Identify and treat laryngospasm if that is the cause, and you may give CPAP. Relieve gastric distension with a nasogastric tube to prevent splinting of the diaphragm and compromising in the FRC. And consider administration of a neuromuscular blocker if you are suspecting that the child is having hyperreactive airway and a laryngospasm. So coming to the best practice statements and the consensus, which are statements which are relevant to face mask ventilation, are that a neuromuscular blockade must be considered to improve face mask ventilation in children. There is a best practice statement, and we have non-randomized controlled trials telling you that it improves the quality of face mask ventilation. Two-handed face mask ventilation technique may be considered to improve face mask ventilation in children. Again, this is a best practice statement because we have a randomized control trial which shows that two-handed mask ventilation technique may be advantageous. And in a Delphi statement, administration of CPAP may improve mask ventilation when difficulty in face mask ventilation is encountered in pediatric patients. We do not have robust evidence, and that is why we ran it through a Delphi process. So we had 100% agreement in the use of CPAP for face mask ventilation. And the fourth statement was the question was whether you should use lateral position, but no consensus was achieved in this particular statement. The prerequisites for laryngoscopy and intubation: whenever you are attempting laryngoscopy, and IV access must be secured because children are have a parasympathetic tone and they are extremely prone to develop bradycardia during laryngoscopy. Appropriate monitoring should be used. Pre-oxygenation in the form of an oxygen-enriched environment is mandatory. Adequate depth of anesthesia should be maintained because if you attempt a laryngoscopy in a lighter plane of anesthesia, the chances of trauma, laryngospasm developing are higher if you have not given a neuromuscular blockade. Nasal oxygen should be administered with nasal prongs catheters during attempts at laryngoscopy and intubation for apneic oxygenation. Use of correct size of equipment is a must. Again, when you are attempting laryngoscopy, use appropriate size equipment. Optimize change in the position of laryngoscopy. Ensure adequate neuromuscular blockade. For each subsequent attempt, consider changing the device, technique, and operator. So device could be either a different laryngoscope blade or a video laryngoscope technique. Use an external laryngeal manipulation or a bimanual laryngoscopy. You have the most experienced operator performing the laryngoscopy. Attempt laryngoscopy only if the saturation is more than 95%. Use intubation aids like bougies and stillets. Use nasal apneic oxygenation. Limit the number of attempts to 2, and the third attempt should be done only if a pediatric expert is available. Again, children are extremely prone to trauma, and the airway could be extremely difficult to secure if repeated attempts are done and the trauma causes significant airway edema. The successful intubation should be checked with capnography with 6 square wave capnography breaths. So this is what I was describing, the external laryngeal manipulation in tiny toddlers, that is maybe a year and a half or 2 years. This is helpful, where the little finger of the hand performing the laryngoscopy can give external laryngeal manipulation, or you can do bimanual laryngoscopy with two-person laryngoscopy, that the person who's performing the laryngoscopy gives the external laryngeal manipulation and gets the glottis into view. If you're doing with a video laryngoscope, you can probably look at the screen, and a second person gives the intubates with an endotracheal tube. Again, the laryngoscopy statements. So video laryngoscopy is not beneficial in enhancing the success rate of intubation compared to direct laryngoscopy, despite improving the glottic view in children. So the glottic view may be superior with a video laryngoscope, but it need not necessarily translate into betterment in intubation, in the success rate of intubation. So this is a best practice statement, and there is no benefit of video laryngoscopy over conventional laryngoscopy in children. But in infants and neonates, it is claimed to be beneficial. Again, what is the maximum number of attempts? We do not have a best practice statement in that. So we do not have evidence, that is why we had run it through a Delphi process. That is, maximum of 2 attempts, and the third attempt should be done only if an experienced pediatric anesthesiologist is available. Coming to the supraglottic airway device insertion, we recommend using a second generation supraglottic airway device, which was similar in the 2016 guidelines. A second generation device improves the oropharyngeal seal, has a better airway contour fitment, and the gastric drain tube can align better with the upper esophageal sphincter and increases the success of nasogastric tube passage and stomach decompression. Number of attempts due to by a Delphi consensus statement should be limited to 2. Resume face mask ventilation between 2 successive attempts. And if the first attempt is unsuccessful, consider changing the device and the type of supraglottic airway that was used in the first attempt. So again, here the supraglottic airway device statement, a maximum of 2 attempts at supraglottic airway device should be permitted to limit the number of complications in pediatrics, and this was again through a Delphi process. So when we use any of these devices, the success rate, the success with intubation should always be confirmed with capnography. If you have used face mask ventilation and that was successful, either you should consider awakening the patient or continue if the procedure is safe to be mind you, you are using this as a rescue airway technique with failed other techniques. So again, you have to weigh the risk and benefit ratio, whether it is safe to continue the case with a face mask ventilation. If you have put a supraglottic airway device, you could either consider awakening the patient or continue with the supraglottic airway device in place, or consider intubation if you have the relevant expertise and the equipment to go ahead with intubation through the supraglottic airway device. And again, you can consider tracheostomy only if it is a part of the surgical plan. Mind you, here again, pediatric tracheostomies are not without danger, and it can be a disaster if they go into a false passage or if they cause pneumothorax or subcutaneous emphysema. So it is best left when it is the procedure demands, and at the same time you have an expert to do the pediatric tracheostomy. Again, this is in a nutshell. You could use any of these devices. So only 2+1 devices at intubation, only if the saturation is more than 95%, only 2 attempts at supraglottic airway device, and not more than 3 failed attempts at face mask ventilation. Whenever you're doing this, continue apneic oxygenation, and preferably the subsequent attempt should be by the most trained member. If you are unsuccessful at any of these devices, then declare emergency surgical airway and complete ventilation failure. So inability to ventilate using tracheal tube or supraglottic airway device or face mask ventilation, declare complete ventilation failure, call for additional help, which could be a surgical expert for tracheostomy, and continue efforts at rescue face mask ventilation through the upper airway. Again, what is different in children? When you are doing an emergency surgical airway and if surgical help is available, you proceed with a tracheostomy. Okay. If surgical help is not available, then and the child is less than 5 years of age, go ahead with a cricotracheal puncture. That is a lower, because the cricothyroid membrane is not easily palpable. There is a lot of adipose tissue and it is much higher. In more than 5 years of age, a cricothyroid puncture is mandatory. Again, here, surgical and cannula cricothyrotomies are not recommended to be used. We use only a needle puncture. And whenever surgical help is available, again, here evidence says that you use a scalpel bougie tracheostomy. That is, you identify the trachea, you put a nick on the tracheal cartilages, put a bougie through that, and railroad a tracheostomy tube over the bougie. So you proceed with the emergency surgical airway before the child begins to desaturate. So this is when trained surgical help is available. When trained surgical help is not available and you are doing a cricotracheal or a cricothyroid puncture, you need to use jet ventilation devices to oxygenate the child and salvage the situation. Again, once the needle is inside the trachea, it is advisable to begin with the lowest pressure of a pressure-regulated jet ventilation device to see a visible chest rise. Upper airway patency has to be maintained for expiration to occur. Okay. Oxygen must be continued through the upper airway for expiration, as well as oxygen entrainment through the upper airway when you are giving jet ventilation. The inspiratory-expiratory ratio should be maintained to 1:4, that is 1 second to 4 seconds for expiration, so that there is enough time for expiration to happen and there is no barotrauma. Cricothyrotomy, again, when you are having a cannula inside the airway, it is important that the cannula doesn't get kinked or dislodged. Otherwise, it can lead to disastrous complications and subcutaneous emphysema. And whenever you're doing a cricothyrotomy or a cricotracheal puncture, a surgical tracheostomy should be done as soon as possible, preferably in less than 40 minutes following any of these needle punctures. Again, the recommendations here, the best practice statement is that whenever experienced surgical help is available, tracheostomy may be considered as the preferred technique in situation of complete ventilation failure in pediatric patients. Again, for the cricotracheal and cricothyroid puncture, there was no evidence because most of the studies that were done were mannequin studies or animal model studies, and it was all extrapolation of adult data. That is why we had run it through a Delphi process, and the expert consensus statement states that a cricotracheal puncture should be preferred in pediatric patients less than 5 years of age for performing emergency surgical airway. And when the child is between 5 and 12 years of age, you could go ahead with a cricothyroid puncture. Again, the post-procedure plan is very similar to the adult. Again, further airway management plan should be chalked out. Treat airway edema because children are extremely prone to develop airway edema. Monitor for complications and counseling and documentation, filling of the airway alert form, and counseling of the parents is extremely important. Thank you very much.
Thank you, Dr. Jason, for again a good overview of pediatric unanticipated difficult airway guideline. Now we'll move to the next segment. Meanwhile, again, I'll request everyone, if you have any query, please put it in the chat box, which is there with the YouTube. Please put it there. We will definitely answer each and every queries. Okay. So next we'll move to airway management during pregnancy, which is actually a unique anatomical and physiological challenges. And we are going to have with us Dr. Ramkumar sir, retired professor, Kasturba Medical College, Manipal, and lead for the obstetric guideline. And he will share the obstetric guideline and the recommendations with you. Over to Ramkumar sir, I will share.
Thank you, Amit. I hope I'm heard, Amit.
Yes, sir.
Yeah, please share the slides from your side.
Yes, sir. Yes.
Because I have a technical problem here. And good evening to everybody. While Amit is getting the slides on, we had, my job has been made much easier thanks to the presentations by Sheila and Jason. What I will do as we go along the obstetric guideline is that I'll point out the similarities and the differences. And of course, once the slides get going, let us start. Yes, the slide is visible here, Amit. Thank you so much. Okay, so again, we thank all the members of the Indian Society of Anesthesiologists and the entire editorial board of the Indian Journal of Anesthesia for having brought out our guidelines yesterday. Though it was a bit delayed, it was exactly on time as we revised our final deadlines. And November 1st was our final deadline, and that's when it happened. Next, Amit. So this, of course, is the title of the article. And we had 14 members in this guideline committee. Next. And we had, Amit, can you go ahead, please? So we had 3 members from the Association of Obstetric Anesthesiologists, the immediate past president, Dr. Kajal, the current president of the AOA, Dr. Anju Grewal, and the honorary secretary, Aruna Parameshwari. All 3 of them stalwarts in the field of anesthesia itself and in obstetric anesthesia. And their presence really bolstered the efforts of the remaining 11 members from the All India Difficult Airway Association. I thank all 3 of them for their constructive inputs and strengthening our guideline. We've gone next, please. So like the other guidelines, we have in the print version, the main algorithm with the description of the algorithm. And we have additional material in the form of appendices, which actually tells you how we went about doing the research, as described by Sheila in the methodology statement, the methodology paper. Next slide, please. So we have the main algorithm here, and once again, as pointed out by both Sheila and Jason, the linear method, which was there earlier in the hierarchical manner, has now changed. And the first thing that we need to remember when we talk about obstetric anesthesia is that unlike the adult and the pediatric, there are two lives involved. Next, please. Next, Amit, please.
Yes, sir.
Yeah. So if you look at the top box, it says the best optimized attempt at intubation using modified rapid sequence induction and intubation with the APL valve close to less than 20 centimeters of water. So the best attempt, click again, please.
Yes, sir. Sir, I'll just go back.
Yeah. So once again, unlike in the other two situations at the adult and the pediatric, the endotracheal tube, tracheal intubation. Sorry, Amit? Yeah. Tracheal intubation is still the primary management plan for the obstetric patient. And because there are two lives involved, the management plan for the mother as well as the baby needs to be discussed in detail with the obstetrician before the anesthetic induction should the intubation fail. Sorry, there's some, I think it's not coordinating the presentation. So now we come to if the intubation has been successful, yes, well and good. And if it is not, as Sheila had already mentioned earlier, there are three vertical boxes, the red, the blue, and the black box that has been shown here. The red box says call for help, code D. The blue box says maintain depth of anesthesia, and the black one says deliver nasal oxygen. That remains same whether it is adult or pediatric. And coming to the orange box now, once again, we have a similarity. There are three options that are given now. Again, like the adult and the pediatric, the endotracheal tube, the supraglottic airway, or the face mask. And these can be interchangeably used. There is no hierarchy as to one is superior to the other. Whichever works in your hands would be the best. So we always do the first intubation in the obstetric patient after optimizing the position. And if the first attempt fails, we need to re-optimize the position, ensure that the neuromuscular blockade is acted, change tools or techniques and operator, and interchange between these three techniques. Once again, with tracheal intubation, as in the pediatrics, it is 2+1 attempt, with the third attempt being done by the most experienced anesthesiologist available. As far as the supraglottic airway is concerned, it is a maximum of 2 attempts. Face mask ventilation, as Sheila emphasized, there is no limit to the face mask ventilation. So 3 failed attempts would be what is to be recommended for us to exit from this orange box and go on to the next box, which is the green box on the right side. Coming up on the right is the old algorithm, which was in a linear hierarchical manner, and that has now been discarded for the circular pattern. We can interchange between the three, and as I've already mentioned, 2+1 attempt for intubation and maximum of 2 attempts of the supraglottic airway. Right. Right. Now let us concentrate on the box, the green box to the right. If tracheal intubation has been successful, the top of the green box says consider tracheal, confirm tracheal placement by sustained waveform capnography. As mentioned earlier, 6 to 7 consistent waveform capnographs are essential to confirm that the tracheal tube is in place. If tracheal intubation is successful, good, you can go ahead. Now, when tracheal intubation is not successful and we have succeeded to place a supraglottic airway device or a face mask, the next consideration would be whether the mother and the baby are safe. Now, if the mother and baby are safe, we can awaken the patient. The mother and baby are not safe, their condition is not reassuring, and we have managed to secure the airway either with a supraglottic airway device or a face mask. There are two options here. The top of this box talks about a failed intubation with a successful placement of a supraglottic airway device. Now, in that, when you go a little down, the first box to the left says there is a leak, and that leak is either audible or quantifiable. The one below that says that there is no leak. That means your supraglottic airway is absolutely perfectly positioned. In either of these cases, we consider delivering the baby. The baby delivery must be completed with the supraglottic airway in place, the supraglottic airway that has been placed as a rescue device. And after that, if there is a leak and if you have equipment available and expertise available, you can consider exchanging with an endotracheal tube through the supraglottic airway with a fiber optic bronchoscope. The lower part of the diagram says that the supraglottic airway is properly positioned. And in these situations, we can continue the entire anesthetic with the supraglottic airway unless and until the supraglottic airway position changes, we lose the actual good position of the supraglottic airway, or a maternal condition warrants it. There's excessive hemorrhage in the mother, or there is a full stomach kind of situation, then we consider changing to a endotracheal tube. Let's now concentrate on the lower part of the diagram where we have been successful with a face mask ventilation. Now, if the face mask ventilation has been successful, then we can have one of three clinical situations. One, the face mask is successfully ventilating the patient. We're able to maintain oxygenation, ventilation, and the anesthetic depth. And the patient is now apneic, or the patient has regained spontaneous breathing and it is satisfactory. So these two are clubbed together. In the presence of adequate face mask ventilation, if the patient is apneic or the breathing is spontaneous and satisfactory, we can continue the entire anesthetic maintaining cricoid force. On the other hand, if spontaneous breathing has recovered, has come back, but it is inadequate or unsatisfactory, we need to consider giving a neuromuscular blocking agent, and then and only then we continue to the anesthetic. Of course, with cricoid pressure being applied. Now, if all the three devices have failed, the tracheal tube has failed, the supraglottic airway has failed, and the face mask has failed, then as Sheila had pointed out earlier and Jason had mentioned, this is unsuccessful. We have now come to a situation where we declare complete ventilation failure, we call for additional help, and we continue our efforts at rescue face mask ventilation. The only option at this point of time is to go for an emergency surgical cricothyroidotomy. Now, at any point of time in our management of the obstetric patient, the patient can go for a cardiac arrest. Earlier, this used to be, known as a maternal cardiac arrest. Now we say it is to be called post-mortem resuscitation. But now the terminology that has come up is resuscitative hysterotomy, and this needs to be initiated within 4 minutes. Somebody needs to be timing the whole period of cardiac arrest, and within 4 to 5 minutes, the baby needs to be delivered. That gives a better chance for both the baby as well as the mother for survival. The post-procedure plan is very similar, like in the adult as well as in the pediatric age group. We have to have a further airway management plan, treat airway edema if it is suspected, especially in the obstetric population, where the physiological change of pregnancy can predispose to a more airway edema and possibly also airway bleeding. Monitor for complications. Counseling and documentation as before. We need to give an airway alert card to the patient or to the relatives to make sure that a similar situation does not arise in future. And with the last slide, I thank the All India Difficult Airway Association for giving me a wonderful group of guideline committee members to work with this, and also the 3 members of the Association of Obstetric Anesthesiologists who bolstered our effort and made our guidelines really robust. Thank you very much.
Thank you, sir, for those wonderful presentation. And I'm sorry, initially, things were not going the way it should be. So next, we will move to the extubation, and I'll call upon Dr. Rakesh Garg, who is professor at All India Institute of Medical Science, New Delhi, and he's a current editor of Indian Journal of Anesthesia. He's part of our all guideline committee also. Over to Dr. Rakesh.
Thank you so much, sir. So after going through all the, just
Meanwhile, we can ask people to type questions if they have any questions.
say the slides visible, sir?
Yes.
Yeah, thank you so much. And after the interesting guidelines of the intubation aspects, let's move towards the extubation guidelines as well. So in these extubation guidelines, thanks to all the authors, the experts, the core committees, and the various people who has contributed nicely for creating, reporting this evidence, as well as certain consensus statement was required to frame up these guidelines. As we have defined in the previous guidelines also, these three definitions are important for to decipher the extubation guidelines: the tracheal extubation, the tracheal extubation failure, and at-risk extubation. So when we say the at-risk extubation, this guidelines is primarily focused on this aspect where the extubation is characterized by a heightened likelihood of post-extubation complications, which may be inclusive of reintubation, hemodynamic instability, or airway compromise. Now, this is what we have retained the three-limb approach for extubation. Though there have been subtle differences as we go along, we will understand those differences. But based on the risk the airway could have, they have been categorized into three broad categories, and which has been labeled as limb, which is the normal airway, the 3Ds, and 3S. Now let's see what differences are there in the existing guidelines that are different from the previous guideline. Definitely, as the previous authors and the core committee emphasized, that all the guidelines are based on the latest evidence, and it has followed a robust methodology, as has been nicely explained by Dr. Sheila Nayan Mitra. And we have used at times Delphi survey and expert opinions wherever required. Now, in this guideline, and another terminology called peri-extubation oxygen, periox, is introduced to emphasize on the need of oxygen supplementation in the peri-extubation period. And this is important because, as we have emphasized during the intubation aspect, the oxygen supplementation for a smaller duration is not going to harm the patient in any way, and hence to increase the safety of these patients even during the extubation part, the peri-extubation oxygen, periox, should be given to these patients during this period. In these guidelines, there have been emphasis on the quantitative assessment of recovery from the neuromuscular blockade before extubation, and hence neuromuscular monitoring has been suggested strongly in these guidelines. Also to emphasize for the first time, which is new in this guideline, a four-pronged strategy for safe extubation has been mnemonic by safe extubation strategy, which again highlights the importance of each step. And this safe says stratify risk, A for assemble and anticipate, F for facilitate extubation, and E for evaluation and escalate. So in this extubation guidelines, not only for adults, but there have been concepts for pediatric extubation also. There are certain differences between safe strategy for adults and pediatrics in this guideline, but it is very important for knowledge gain, understanding, stratification, and safe extubation. This safe strategy would be helping all the clinicians in a big way. The present guideline emphasizes three-limb approach to extubation, and these three limbs primarily pertains to some at risk of extubation. Limb 1 is focused on suppressing the hemodynamic response during extubation. That is something required for neurosurgical procedure, vascular procedures, or ocular procedures. Limb 2 emphasize on stage sequential extubation, an important technique. Limb 3 emphasize on delayed extubation. Now, this stage sequential extubation and delayed extubation emphasizes the importance based on the airway assessment at the time of extubation, and hence a decision can be taken easily. These guidelines also have put very important features, differences for pediatric extubation, because we understand pediatric is not young adults. They require different management strategies, just has been mentioned by Dr. Jason in pediatric guidelines, and hence extubation is also having subtle differences, which has been nicely expanded in this extubation guidelines. These guidelines also include certain peculiar features, situations which can happen during extubation, like unexpected extubation failure, stuck tracheal tube, and tracheomalacia situations. It has emphasized on some important aspect also. Now let's see this guideline. Now, as I mentioned, the peri-ox, that is peri-extubation oxygenation, needs to be continued throughout these steps of extubation. That's the primary thing before we start extubation. Now, based on the three components, three limbs, or three categories of the patient population requiring extubation, they have been approached as limbs: normal airways, where the attenuation of hemodynamic response requires 3 days, difficulty, delayed recovery, or difficult face mask ventilation; and 3S, suspected airway collapse, suspected airway edema, or surgical cause of airway compromise. So based on this, a decision can be taken. But remember, whenever you try to differentiate between these aspects, always keep difficult airway cart ready. Ensure neuromuscular blockade has been reversed appropriately. Call for have lung requiem. And based on this, you can think of awake extubation for limb 1 or deep extubation. For limb 2, you can think of stage sequential extubation, primarily in the operating room. And in limb 3, you can think of delayed extubation depending upon the response. And you can use here the airway exchange catheter or wire for extubating these patients once they are optimized. But always remember, sometimes failure can happen, especially when we're talking about 3S, limb 3. Be prepared for reintubation or planned tracheostomy if required. As we emphasize that the peri-ox, you can consider CPAP, NIV, or HFN node, depending upon the patient requirement for oxygen supplementation, and then you can wean it off as per the clinical status of the patient. Now, this is the SAFE strategy. This is universal strategy for safe extubation. As stratify risk, assess your patient for various risk factors which were there at the time of intubation or during the surgical procedure. A stands for assemble and anticipate. You gather resources, anticipate challenges. It includes the manpower. It requires a difficult airway cart. Facilitate extubation, plan a procedure, support the extubation process, and evaluate and escalate. You need to monitor these patients, and in case if extubation failure happens, if there is some complication, if some edema, then you need to escalate if needed. And that's the newer addition to the extubation guidelines by the IDA. The extubation limb, we were talking about limb 1. We talked about these 3 procedures wherein you can obtain the hemodynamic response at extubation. You can remove the tracheal tube and plate supraglottic airway devices, ventilate, optimize patient, and extubate and remove the supraglottic airway device. The other technique where you can insert the supraglottic airway behind the tracheal tube and inflate the cuff and then remove the tube. The third technique includes the use of airway exchange catheter, where you can put up an airway exchange catheter while tracheal tube in situ. Then you can remove that the endotracheal tube and put up the supraglottic airway device. And once the patient is spontaneously breathing, neuromuscular blockade is reversed. You're monitoring using neuromuscular monitor, and then it can be removed safely. So these are for where you want to obtain hemodynamic response, because we understand that the supraglottic airway devices creates less periglottic or glottic responses, and hence the hemodynamic perturbation will be less. In extubation limb 2, where we talk about stage sequential extubation, it is basically a structured stepwise approach for patient with high risk, which we have just talked about 3 Ds. And this technique involves the intentional removal of endotracheal tube while preserving airway access using a temporary conduit, which could be an airway exchange catheter, or it could be an extubation guide wire, which is commercially available. Even the extubation kit is available, which can be used, but airway exchange catheter being available, it can be used. And in case required, the patient can be reintubated using these devices easily. So this is the important strategy for limb 2 patients. In extubation limb 3, where we had talked about 3S, the delayed extubation, where the procedure of removing the tracheal tube after the patient has been transferred to a ICU or a high dependency unit means a monitored environment where the resources, including the equipments and the human resources are available. And this approach is planned when concerns about potential airway collapse, airway edema, or surgical factors may compromise airway integrity, leading to collapse of the airway. The stridor can happen, and in those situations, think that comes into category or limb 3, and delayed extubation is required. When we talk about pediatric extubation, same safe strategy is applicable. There are subtle differences which has been highlighted in pediatric population. They have less apnea reserve. They can go more into edema. They can have issues of laryngeal edema. They requires more expertise, which has been emphasized by Dr. Jason in pediatric guidelines. Similar concerns remains during extubation and hence needs to be taken care of. Now, this is additional algorithm which has been incorporated into this guideline, which is unanticipated extubation failure. We have talked about earlier where the airway exchange catheter is put, but herein, if you have extubated them, there is no airway exchange catheter in this. In those situations, if the extubation failure happens, means there is signs of patients not maintaining the airway after the tube has been removed. In those situations, as we talked earlier, code D needs to be activated. You achieve rapid and reliable oxygenation. You can use face mask or supraglottic airway device, or you can use HFNOs. And if you can establish a reliable, safe apnea period, condition improves, you can continue oxygenation or ventilation and observe. But if the condition does not improve, you need to reintubate them. If fails, reoxygenate, and then refer to the earlier guidelines which we have discussed for adults and pediatrics. If you are successful after the reintubation, then you can plan the stage sequential extubation once the patient is optimized. So this is an additional guideline which is very, very important in case if we have extubation failure. As mentioned in the previous guidelines also, the post-extubation plan again remains important for these patients. There can be complications, especially when we talk about difficult airways. The administration of periox, supplemental oxygen, and the monitoring is important. Appropriate suctioning, head-up positioning, bronchodilators, if patient requires, needs to be continued. And we have already talked about in the previous guidelines by Dr. Sheila Maitra about the airway alert forms. So it's not only for intubation, but even at extubation, if you have faced some difficulties, they need to be mentioned in the alert forms, kept in the record, and given to the patients as well. Thank you so much, and we are open for any questions or comments from the listeners and the experts.
Thank you, Dr. Rakesh. Yes, the floor is open for question and answer. And we have two queries from the YouTube where many delegates and attendees were looking at it. Dr. Meghna, Dr. Abhinav actually said, well done, Team IDA. Thank you, Dr. Abhinav. Dr. Meghna said that this is to Dr. Ramkumar, sir. Regarding 4 minutes of resuscitative hysterotomy, baby should be delivered within 4 minutes of cardiac arrest or 4 minutes of ventilation failure. So, when should we start thinking about resuscitative hysterotomy? Within 4 minutes of cardiac arrest or 4 minutes of ventilation failure? Ramkumar, sir.
Yeah, we think of resuscitative hysterotomy straight away, the moment arrest happens, and the baby should be delivered within 4 to 5 minutes for it to be beneficial both for the mother as well as the baby. The chances of survival of the mother and the baby increases if the delivery happens within 4 to 5 minutes. So we initiate resuscitative hysterotomy the moment cardiac arrest is detected.
Okay. Thank you, sir. So it is with the cardiac arrest after once you detect the cardiac arrest, within 4 minutes you should start.
Yes.
Dr. Neeta Kavishwar has asked, should we do laryngoscopy while extubating the patient? Dr. Rakesh. So anyone can answer. Of course, everyone is author and everyone has contributed, so anyone can answer. Should we do laryngoscopy while extubating the patient?
So we have mentioned at one of the point in the guidelines also, if you are thinking there could be some secretion, some possibility of the bleeding aspect or clots, in those situations, you can do a gentle laryngoscopy. Probably I will say it epiglottoscopy, not the laryngoscopy, to look on those areas, do a nice sectioning, and then you can extubate it. But routine laryngoscopy for all patients are not required. So we have already mentioned 3 aspects here where we want to obtain the response. So first, laryngoscopy can elicit sympathetic response for limb 1, so it's not usually recommended. For limb 2 and limb 3, we have talked about stage sequential extubation and delayed extubation. So the routine laryngoscopy is not suggested, but yes, for purpose of viewing and suctioning and removing clots, they can be done.
May I just add one comment to the previous question, Dr. Amit?
Yes, yes,
So
Dr. Sheila.
I just want to say the reason it is post cardiac arrest, because this situation can occur at any point. It is not only after complete ventilation failure. At any stage, this can occur. And that is the reason why the red hexagon is outside the algorithm. And we have specifically said that at any point. So a lot of time people think it's after complete ventilation failure, but it might be, in the initial stage, it might be even when you have not succeeded in ventilating with the supraglottic airway device. So it's important to remember that it's immediately post cardiac arrest. We're talking about 4 minutes.
I agree. With the way earlier, if you see 2016 guideline, it was at the end of, the linear process. And it was when even our, this was also failed, like, the emergency cricothyrotomy, whatever we are planning, if it is not possible, and then it was there. So now we have moved it to a right side, separate from our algorithm, and it can be done at any time, whenever there is a cardiac arrest. Dr. Jagruti has asked, yes. Yes.
Yeah, that's okay, sir. Continue.
Yeah. Dr. Jagruti has asked, it is about, not exactly about guideline, but smaller size of it is for extubation. Smaller size of endotracheal tube, patient tolerate for longer time and late extubation is permitted. Like number 7 for female, 7.5 size for the male patients. Please share your experience. So are we like, if there's a smaller size of tube, do you keep on tube and, not exchange it to airway exchange catheter? That is what I feel what she probably wants to ask.
This is an important question because if you see a couple of years or decades back, we used to say the largest size tube should be used, 7, 7.5, 8, 8.5. I was also 9 tube was also available. But now with the better availability tube, better availability of cuff we have. So we are using not the largest size tube in any of these patients. And probably as the Dr. Jagruti also mentioned, 7.5 for female, 7.5 for 8 males is usually sufficient for Indian population because we don't want to cause trauma to the tracheal mucosa because a lot of incidence of tracheal stenosis is happening. When she talks about the tolerance of the tube, I think you are giving good anesthesia, so they are tolerating because we don't want them to have cuffing, bucking, and all those sympathetic responses. So I must congratulate Dr. Desai that she is giving good anesthesia so that a safe, smooth extubation is happening in these patients. So it's both your technique, your experience, and using the appropriate size tube, not the largest tube.
If I may, I just add a comment to this.
Yes.
Yeah. So the thing is, the question was about using airway exchange catheter. So I don't think they are interchangeable, that you can overcome this by using a smaller size tube. Yes, definitely. I agree with you, Dr. Rakesh, that we have moved towards using smaller size tubes. In fact, even the airway exchange catheter is considered, to be big. And that is why you have the stage extubation catheters where you can actually put a guide wire through the airway exchange catheter, remove the airway exchange catheter and keep just the guide wire because it may be better tolerated. So I would say keeping a smaller size tube doesn't serve the purpose because the idea is to extubate the patient. And if a reintubation is required, then either put the airway exchange catheter over the guide wire or put the tube over the airway exchange catheter. So I think the question was whether you could interchange this, replace the airway exchange catheter with putting a smaller size tube. Thank you.
Okay. So Dr. Anand and Sashidharan had amazing guideline. Congratulations, team. Dr. Anand has asked, lignocaine in cuff inflation, do you recommend for every intubation? Rakesh.
With saline or lignocaine?
No, lignocaine. So that is 2A, 2B recommendation is there in our, So, Dr. Anant, what we have seen is that when we have gone through the literature, though it is not widely practiced, the literature, including some of meta-analyses are there, which suggest that it can improve. It definitely reduces cough and laryngopharyngeal sequelae, that means cough and other problems, sore throat and other problems. Hemodynamic, it is not a very robust evidence even in those meta-analyses. But those meta-analyses were not very, I would say, robust in their methodology. So we have reduced that recommendation, but yes, it can be used, and if it can be beneficial, that's what we have mentioned. Dr. Sheila, if you
Yeah,
want to comment on this.
actually, we really struggled with this one because when we reviewed the literature, we were quite stunned because this was not part of any of our practice to put lidocaine, in the cuff and then when we looked at like Dr. Amit rightly said, when we looked at the quality, there are meta-analysis, so it would have probably gone to but we downgraded it because the quality of the evidence, I mean, the quality of the studies that were included in the meta-analysis were very small studies, and there was a lot of heterogeneity in the studies that were included, and that is why we decided that we should not give it a grade 1, and we came down to 2A and 2B.
So yes, we have suggested that it is a beneficial. You can, okay, Dr. Sheila is still picking up.
No, no,
So
no.
what you
We can always suggest audiences because if you see the best practice statement and consensus guidelines, I think these guidelines has provided a good number of ready-made research questions which are there. So wherever we have gone for a consensus statement and best practice statement, I would suggest please pick up and give the thesis questions or faculty projects, because we do not have, the core team has done an extensive review of literature, and based on this, the best practice statements and Delphi consensus was achieved where there is no evidence. So there are many questions, and I'm sure that each one of you can give thesis to your students for at least 1 year, and it will give a lot of help to guideline developers across the world to make a robust guideline in the next revision.
Okay. Meanwhile, there are two more questions. One is, when is the ideal time to perform leak test for the suspected tracheomalacia?
So again, the guidelines have very well described when to do it, how to do it, and how to interpret. So when the patient is under surgical plane of anesthesia, when the patient is being mechanically ventilated, so this is the time you should do a cuff leak test. The technique that has been used, patient should be on a mechanical mode of ventilation, the volume control of ventilation. The tidal volume should be fixed. The guidelines suggest 8 ml per kg of ideal body weight. And also, two techniques have been described. The conventional techniques remains the quantitative test of leak test, wherein you look for the leak with cuff inflated versus cuff deflated. 110 to 130 ml or 25% difference. If it is more than that, this means there is no edema. If less than that, probably there is a chance of airway edema. Nowadays, since POCUS is very well available at many places, people are experts in using POCUS for airway. You can also look for using a linear probe. You can use it and look for the air diameter in the laryngeal structure. And then based on this, if it is less than 9 mm, you should be a little cautious about the presence of airway edema and be cautious. So this is the process of doing cuff leak test before suspected, when we have specifically talked about 3S situations wherein it becomes important to do it. But wherever you suspect, the cuff leak test can be done, easy process.
Amit, if I may.
Dr. Sheila. Yeah, Dr. Sheila.
So, Dr. Rakesh has very beautifully described how the cuff leak test is done. And I'd just like to make a point here. The cuff leak test is specific for airway edema. It is not meant for tracheomalacia. And the reason is because when you have tracheomalacia, this is actually an exception for not doing the cuff leak test. You have dynamic airway collapse. So when you have dynamic airway collapse, the cuff leak test will not help you. It will help you when there's airway edema because it's a dynamic situation. So in that, as you can see in our algorithm, we also recommend the use of a flexible bronchoscope. And this can be really useful in a situation when you want to extubate a patient with tracheomalacia and preferred over an airway exchange catheter. You can put the bronchoscope distal to the tip of the endotracheal tube. You can deflate the cuff and you can simultaneously withdraw both the tube and the flexible bronchoscope. And this way you can evaluate as you remove the tube, you can see whether there is any dynamic airway collapse. And if you visualize dynamic airway collapse, you can just slide the tube back and, you need not extubate the patient. While you use an airway exchange catheter, you might land up extubating the patient. Patient will go back into stridor and you have to readmit. So as is suggested in the extubation guidelines, this is one specific area where the flexible bronchoscope helps. Whereas if you look for cuff leak test with dynamic airway collapse, because it's variable. What you will get is a variable situation. It's not like, a leak or not having a leak when you have a airway edema.
Rakesh, if you want to read,
Yes, which Sheila ma'am has nicely differentiated between tracheomalacia and airway edema. And that's why the safe strategy, when we have mentioned, the S stands for the planning of the extubation in this aspect. So herein, when we say tracheomalacia, you need to correlate with the previous history of long-standing some mass there, intraoperative finding of tracheal cartilage softening, which we can ask. So definitely, you also need to consider these factors when you are planning for safe, and then stratify and make a strategy for the extubation in the. So this mnemonic specifically, which IDA comes to my knowledge, is for the first time, the safe strategy for adults and pediatrics. I think this will give a good impetus on understanding, knowledge, creating more research, and safety of patient in the extubation part also.
Just one
Dr. Sheila.
like to add, indeed, SAFE is a very, very good value addition to our extubation guidelines. I also want to say that when I speak about tracheomalacia internationally, people ridicule me saying that this is a non-existent entity, and that is not true, because we see a lot of tracheomalacia at Tata Memorial Hospital because we get large thyroid masses, etc. Now, the people who see it are not the people who publish it and report it. And that is why they say the incidence is very low. So it is a reality. And as Dr. Rakesh has rightly said, the surgeon will give you a very nice clue as to whether, the tracheal rings are soft, or, you will get, and how long-standing it has been. So there are a lot of hints that you can get. And even if you extubate these patients on table, and you take a chance to do it over an airway exchange catheter or whatever, and you re-intubate these patients, remember that these patients, you're keeping the tube in only to stent the trachea. You don't need to ventilate them. You can even keep them with the tube or just on pressure support, because what you're doing is keeping the tube to stent the trachea, but don't extubate them immediately after a day or so. You need at least 48 to 72 hours, because the goal is that you're trying to hope that, some fibrosis sets in and the trachea gets stabilized, following which you will extubate. Otherwise, if you extubate after a few hours, again, you will fail the extubation. And here, as I mentioned, the bronchoscope will be very, very handy in extubating these patients. Thank you.
Dr. Jason.
Yeah, I agree with Sheila madam here that people who say that they haven't seen tracheomalacia, I don't think they've done enough work. I have a couple of videos which we have at Tata Memorial Hospital, and we put the fiber optic bronchoscope, and you can see the dynamic collapse of the airway. So it's not unusual. It may be rare in institutes which do not cater to a population that actually is prone to develop tracheomalacia.
Okay. Thank you, Dr. Jason. Yes, madam.
Not published. And like Dr. Rakesh said, we should publish this. Otherwise, they will say that this is a very rare entity.
Okay. There is one by Dr. Anant who is asking about ultrasound in difficult airway, though it is unanticipated. Anyone can comment on that. Importance of ultrasound in difficult airway management.
When we say ultrasound, if you see the last 2 years literature, a lot of studies are being published in various journals, including IJA, BJA, and SCNLGCR. There have been a couple of good papers. And if you see the parameters that have been found to be very useful are the tongue volume, the pre-epiglottic space, and the laryngeal edema. So they have been found to be very, very important. People have considered various markers, thyroid distances, and other markers also. We do not have a robust scoring system of measuring few parameters. It has not been created. So another area of research, if we can identify with some regression analysis or some collection of parameters to reach that these 3-4 parameters, if this value they come up, they can be important. But yes, it is a useful tool. It's a dynamic tool, and certain parameters are important. You can always use them, and number of studies have been published. And I remember 1 or 2 meta-analysis has also been published in this area for few predictors of difficult airway using the point of care ultrasound.
Okay.
I may have missed you. I think one way, place where ultrasound can really help us is when there is an aspiration risk. And I think we have given a recommendation for that. Can you elaborate on this? Because that's one place where very quickly you can assess the gastric volume. So can you
Ramkumar sir.
So Ramkumar sir,
Hey. Just a phone.
So there are a couple of points which we have mentioned into our guidelines before Ramkumar sir unmute himself. So one is, as Dr. Sheila mentioned, we can always measure the enteral volume of the stomach. We understand that the gastric emptying time is different for different population. We also understand that different type of foods have different gastric emptying. Indian population sometimes have a heavy meal which can take 8 to 10 hours. And the India being a diabetic country, gastroparesis is an important aspect. So based on these parameters, if you can assess the gastric enteral volume, this will given the amount of residual volume, number one. Number two, you can also differentiate between whether it's a clear fluid or it's a gastric contents with some food materials. So this can also be differentiated on ultrasound. So based on this, you can take a decision whether this patient will have a high risk of regurgitation and aspiration. And second, as Dr. Sheila was mentioning about, this has also been used when we talk about surgical airway. In certain situations, we have a good robust landmark to look for the cricoid membrane. So though we have not talked about using it as an emergency surgical keratotomy, but yes, in a planned situation, we can always look for to identify the surgical plane, surgical site using the point of care ultrasound when we are looking for subsequently for percutaneous tracheostomy or surgical tracheostomy. So these are not part of actually the guidelines, but yes, this has the another role when we talk about the use of ultrasonography. Ramkumar sir, you were saying something, sir. Sir, you are muted, sir.
So can you tell us
Sir is muted.
that the recommendation that was given in the guideline? Ramkumar sir, you're
Yeah,
muted.
Sir is muted actually.
Now?
Yes.
Yes, sir.
Yes.
Yeah. Okay. So there were two parameters that were looked at. One was the cross section, the gastric cross sectional area, and that had a very varied value, somewhere between 3.8 to 10.3. So something that was more definite, which had a narrower range that was quoted, was a gastric volume measured in the semi-recumbent position or the lateral position of more than 1.5 ml per kg. Some papers said 1.4, some said 1.5. So the majority agreed that anything more than 1.5 ml per kg of liquid present in the stomach would contribute to an aspirational risk.
Okay.
That's what
Thank
was,
you,
that's what came out of the various papers that we reviewed.
Okay. Thank you, sir. And I think we are actually beyond our scheduled limit. But if any other members, those who are present here, would like to comment, they are welcome before we can conclude. In meantime, if you can, all of you can, all three adult, pediatric, and obstetric guidelines. If you want to tell, describe anything which was because, of limit of time, you may not be able to, you wanted to emphasize, but you could not do it because there was lack of time. Like, how it is different than 2016, this guideline or emphasis of putting intubation through supraglottic airway with the help of fiber optic bronchoscope. Anything else you want to emphasize?
There's one question. I think something's coming.
No, madam. Right now, I don't see. Okay. So I think we have. I think we had an excellent session. Yes. And really, good presentations, good description of our new guideline. And we urge everyone to, go through it and completely. These are very big documents. You should also go through not only the main document, but also appendices, which is a separate document, which is available through the supplement. So at the end of that, if you go to that PDF, there is a supplementary document, and there, if you click on the link, that will open up. Okay. Also on our website, we have now uploaded the QR codes. So if you want to access, just go to ida.in, and if you just scan that QR code, if you are doing it through mobile, you just put your press over that, and it will straight away open to the main guideline document on Indian Journal of Anesthesia. So I thank all the present, all the authors, those who are present here, for doing a very wonderful interactive session on our new published guideline. So let me, as the session is being near to the close, it's my privilege to invite our distinguished leader for the concluding reflection. First, I'll ask Dr. Sumalata, Professor and Medical Superintendent K. Segde Charitable Hospital, Mangaluru, and immediate past president of FIDA for her closing remark.
Good evening to all. I hope I'm audible, Amit. Dr. Amit,
Yes, madam.
am I audible?
Yes,
Audible,
yes.
Yeah, you're
Okay.
audible.
Good evening, all, and thank you all for joining us today for this important discussion on airway management. Your inputs and your questions prepare us for further improvement in our process. I hope you found the presentations informative and the question and answer sessions enlightening. As healthcare professionals, we all recognize the critical role that effective airway management plays in patient outcomes. I'd like to extend my gratitude to our esteemed speakers, our guideline leads, for sharing their expertise and insights with us today. To all our attendees, I encourage you to continue exploring these best practices and staying updated on the latest developments in airway management. Your dedication to delivering exceptional patient care is truly commendable and is related closely to what you learn through. Until next time, stay safe and keep learning. Thank you for being with us today.
Thank
Over
Thank
you.
you,
to
Dr.
you.
Thank you, Dr.
Thank you, ma'am.
Suma. And finally, to conclude this session, we'll honor to have Dr. Saeed Moeed, President of All India Difficult Airway Association and Vice Chancellor of Al Karim University, Katihar, to give his closing note.
Thank you,
Quick,
Dr.
sir.
Amit. I hope I'm audible, right?
Yes, sir.
Yeah. So thank you, Dr. Amit, for that introduction, and respected senior members of IDA, the members of AOA and IAPA, and the EC members of IDA as well, and and the today's viewers. Good evening to all of you, and greetings from my university, Al Karim University. I must congratulate the whole team, especially the speakers today. They could dissect the guideline point-wise and emphasize the differences between the previous guideline and the Herculean task they have undergone. We have already taken to present the present guideline, and which is evidence-based, and a lot of brainstorming sessions has been done before we came up to this, though it was an Herculean task, but ultimately it was really a satisfying task. For the last 2.5 years, been doing a lot of work on this. And at the same time, it is, I must also put it on record, especially the IJ, Indian Journal of Anesthesia, and the editors as well, for giving us that space and making this guideline black and white and see the light of the day. Because obviously it has been a rigorous work by them as well, and going for a review and peer review, and everything was done, and we did it in a very very cautious way, that nothing has been missed. I would also request all the viewers who have really attended the session today, because of course we have done our job, and our job does not end here. It is our responsibility also to promote and disseminate this knowledge which we already acquired through this while making this guideline to all the viewers, and make it, and most importantly, the guideline has been made so simple and user friendly. And I would always request them to go through this guideline and use it on a daily regular practice. And also the senior teachers also to at least to train and teach their resident doctors, and make it much more obvious and prominent throughout the nation and throughout the world as well. And I would also I request all my senior faculty members, senior members, and my colleagues to tell their resident doctors, to tell their fellow colleagues that this should not, the end is not here. We have to go ahead, we have to promote it, and we have to really go on. Lot of dissemination of this knowledge has to be there. Otherwise, the guideline will not be obvious and prominent. So I would not take much time. Thank you so much for the presentation to all the speakers, and the way they have emphasized the guideline and dissected the guideline, especially the point was, and answered the questions made. And I'm also thankful to the viewers for putting up those questions, which were really very pertinent and the guideline while doing our guideline. And we were very thorough about it. We know what is where, what is being done. Thank you once again, Amit. You can go ahead with the proceedings.
Thank you, Mohit sir. So, on behalf of AIDA, I extend a heartfelt thanks to all our speakers and participants. Your engagement, today reinforce our shared commitment to making every airway a very safe airway. Thank you all for joining, and we look forward to seeing you at AIDA session in ISACON 2025 Raipur, where we have a AIDA session on 28th November this month in afternoon. Please join us at AIDA session in Raipur. Thank you all. Have a wonderful evening. Thank you.
Thank you.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you, sir.
Thank you,